Welcome, everybody, to week number 7. We're halfway there. We're going to take some time this week to look at some different topics. First one is going to be our chapter 5, which is going to be about our economics of the United States healthcare system. We know that we have healthcare disparities that we come across. Affordable Care Act and the Prevention and Public Health Fund has helped us with this. Our healthcare disparities or differences among population groups in the availability, accessibility, and quality of healthcare services. And we know that health economics is particularly important to community-oriented nursing because they are the ones that are often in a position to allocate resources to solve and help in different programs. So we take a look about our health economics. Now, in our public health economics is going to be the science concerned with the use of resources, including the producing, distributing, and consuming of goods and services. With health economics, it's really concerned with how scarce resources are affecting our healthcare industry. Public health economics is going to focus on the production, distribution, and consuming of goods and services as they relate to public health and where limited public resources may be best saved. 4 principles that we take a look at to explain how public health financing may occur. Source and use of monies are collected solely by the government. Government controls the money, but the private sector will decide how money is used. Private sector controls the money. Government controls how it's used. And the private sector can control the money and how it is used. So those are our 4 different pieces that we take a look at. When we're looking at our different things with our factors affecting resources and allocation in healthcare, we know we look at the uninsured, our poor Americans, access to healthcare and services, Medicaid, safety health net providers, and our Affordable Care Act. When we take a look at our primary prevention, one of the 4 major factors that's going to affect health: personal behavior, lifestyle, environmental factors, human biology, healthcare system. Medical services are said to have the least effect. Behavior and lifestyle is being shown to have the greatest effect with our environment and our biology helping out there. We also take a look at the U.S. Preventative Service Task Force. We look at our recommendations from our Agency for Healthcare and Quality for clinicians. We look at regular screening and risk factors to identify at different ages. So our community guide, our Community Preventative Service Task Act, emphasizes population-led intervention to promote primary prevention. With our Healthy People 2030, we're going to see goals or examples to provide better access to people of all ages. Our healthcare systems have developed in 4 phases from the 1700s through 2019. And so we look at these developmental stages as they correspond to different economic conditions. Developmentally, our 4 components of the healthcare system have changed over time, reflecting macro level or societal changes in morbidity and mortality, national health policy, as well as economics. When we look at our challenges for the 21st century with economics, we do know that we have larger foodborne outbreaks, acts of terrorism or chronic disease is elevated, health disparities is tremendous, technology and its sources, and our Affordable Care Act is something that we'll talk about in class. Given that economics and healthcare are concerned with resource use and decision-making, any discussions of the economics of healthcare must consider past and current healthcare spending. So past spending is going to reflect those past decision-making, likewise with our society and our policymakers. So we take a look at our factors that are influencing healthcare costs. We know that our life expectancy is increased. We have our baby boomer population, so we're having a large population of older clients in the United States. Technology and chronic illnesses are on the rise. We see different financing through public support like Medicare and Medicaid, which we talked about in week 6. We also have public health, other public support like TRICARE, which is for our Veterans Administration. We have private support, so we have different health insurances and employers and how they are managing care. When we look at our healthcare payment systems, we have several methods that are being used by the public and the private sources. So we see that we have different types of reimbursement. We have fee-for-service, preferred providers, reimbursement for nursing services. Nurses must plan for future challenges in healthcare financing and become aware of the cost of health services, identifying aspects of care where cost savings can be safely achieved, and developing knowledge on how we can get that done effectively economically. We need to focus on improving the overall health of the nation, defining its contribution to the health of the nation, and deriving the value of nursing care and ensuring its economic viability. So this is our chapter 5 that we're going to be sharing, and then we're going to take a look at our next chapter, which is going to be chapter 11, and I will share that with you in just one moment. We're going to be taking a look at chapter 11, which is going to be infectious disease prevention and control. We also will talk about child abuse and older adult abuse this week. So when we look at our introduction, our topic is complex. We know that about infectious disease. We look at a study and variety of organisms, pathology that they may cause, their diagnosis, their treatment, prevention, control. I also know a global perspective and that currently some infectious disease are reappearing in the United States, such as measles, because we're not seeing that consistency with vaccinations. Although not all infectious diseases are directly transmitted from person to person, the term infectious disease and communicable disease are oftentimes interchangeable in our reading. So we look at our history from the 1900s, we had communicable diseases being the leading cause of death. And by 2000, we've had improved nutrition, sanitation, vaccines, and antibiotics that has put an end to this epidemic. And we see new killers emerging, such as we had COVID that we've all just been through. Infectious disease is a mean of terrorism as well, which we may start to see that. So we have our epidemiological triangle of disease. We have our agent factors, we have our host factors, and we have environmental factors. We have different modes of transmission with our communicable diseases, vertical, horizontal, common vehicle, and with vectors like our Lyme's disease and our other type of illnesses caused by animals. We have an incubation period where we look at it and the communicable period, and then we have spectrums that it can go through. When we do a good surveillance system, we collect and organize and analyze current and accurate and complete data for a defined disease condition. Our resulting information is then released to those who need it for planning. We look at our reportable diseases. It's going to vary state by state, and know that we will report to CDC if our national disease system, surveillance system states that's where we spread it along. So we have emerging infectious disease. COVID-19 was a big one. West Nile virus we see coming back again. Tables 11.1 and 11.2 are good to look at our factors that influence the emergence of new infectious disease and examples. When we take a look at our role as the nurse in prevention, we're going to be controlling, teaching about, monitoring, and treating people. So our primary prevention seeks to reduce our incidence of disease by preventing it before it happens. Our secondary prevention is going to prevent the spread of disease once it occurs. And our tertiary is going to work to reduce complications and disabilities through rehab and treatment. We take a look at some of the agents of bioterrorism. Know that the attacks of September 11, 2001 showed the potential and possibility of bioterrorism in this country. When we look at our vaccines that are preventable, we're going to make sure we're following our immunization schedules with our measles, our mumps, rubella, our pertussis or whooping cough, our flu. And we also have those that are out there for chickenpox that we encourage in the school system. So things that we can think about that are preventable with vaccines. We take a look at some different foodborne and waterborne diseases, which are in box 1113 that I want you to take a look at. We have our vector-borne diseases like our Lyme's disease, Rocky Mountain spotted fever, rabies. So prevention of tick bites, and we know that that is important with our anti-insect spray and repellents, and we want to keep that down. We saw a rise in Lyme's disease over 2000, and are hoping that we have helping to have that rate come down. We know that we have individuals traveling outside the United States, so we need to be aware of those precautions, like with malaria, foodborne and waterborne diseases, and also our diarrheal diseases. We're going to take a look at our healthcare acquired infections, or infections that are acquired during hospitalization, something like a MRSA, or developed within the hospital setting. Many involve patients, healthcare workers, visitors, anyone who's in contact. Universal precautions is what we're going to use to help to prevent those exposure to our bloodborne diseases like hepatitis and HIV. So that about covers just a quick summary of what we're looking at with our infectious disease. We're now going to take a look at the next chapter, which is going to be chapter 12. And with chapter 12, we're going to look at some of our disease risks. We do know that our that our risks often change, and we know that we need to keep track of our resistance of methods to treatment, and new diseases emerge, new treatments are developed. So we take a look at HIV. We know our history on this one. One of the world's greatest public health challenges, lifetime costs are enormous. What we have found is that we see an overall rate of the highest adults 25 to 29 and then 20 to 24. So we're going to be teaching safe sex prevention here to prevent that spread. We know we sometimes will have a clinical latency where the body shows no symptoms. We know it's from exposure to blood, semen, secretions, and breast milk. HIV, when we look at our surveillance and our epidemiology of it, some are unaware, some are transmitted through sexual behaviors or needle or syringe uses. So we look at it's going to affect high rates on minorities, male-to-male sexual contacts, and transgender women. When we're testing for HIV, we offer in many locations screening. We have a rapid test. We have a routine voluntary HIV test and things like that. When we care for these clients in the community, we're going to make sure we identify resources. We're going to assist employers by educating managers about how to deal with ill or infected workers. We're going to teach about our pre-exposure prophylaxis and our antiviral therapy. We have a bunch of other ones. We have gonorrhea, syphilis, chlamydia, herpes, HPV as well. You're going to do some reading about those in this chapter. We have our 3 different hepatitises. A, which is usually through water or food, can be sexual contact. B is through blood and body fluids, and C is through blood and body fluids as well. We take a look at tuberculosis. We're going to see this in places like jails or where there's high quantity, close living quarters. Our role as the nurse in preventing communicable diseases. We're going to be a counselor, educator, advocators, case manager, primary care provider, and a community outreach, and reinforce our standard precautions. So you guys did some work on infectious disease this week, so this goes along with what you guys have done. We'll review again in class some of the particulars of our communicable diseases, but just a brief summary of what our chapters spoke about. And we have one more chapter that we're going to look at, and that's going to be violence and abuse. And we'll take a look at that PowerPoint right now. All right, so we take a look at chapter 27 is our violence and human abuse. So we're going to take a look here. Sorry, stop sharing my screen for some reason. All right, we're going to take a look here at our introduction, and we know that violence is a public health and social developmental threat, leading cause of death and disability that affects our youth, low-income populations, and those of color. Know that we're more qualified sometimes to respond to violence, so we have to be very sensitive when we are doing that with our patients so that we can help them feel comfortable telling us about this. We have interpersonal violence and community violence, which intimate partner violence, sexual violence, and self-directed violence like our suicides. Our public health to prevention with our violence prevention, please take a look at figure 27.1. It's going to be developed a step-by-step approach. So we identify the problem, who, what, where, when. This is our epidemiological approach. We identify our risk factors. Why does one person or one community experience violence and another does not? And then we're going to implement our strategies from our next step. So we take a look at our CDC 4-level socio ecological model, and we take a look with our individuals, the first level, which identifies biological and personal history factors that may increase the likelihood of a person becoming a victim. In addition to risk factors, others include education, substance use, a history of witnessing abuse as well. Societal, depending on who we're around and the type of community that we're in, we may see more violence. So different violence against individuals or oneself. We have homicide, which is a killing of one human being by another. Assault is going to be a physical or verbal attack. Sexual violence is going to be forcing a person to take part in a sexual act. Human trafficking, which is a big one right now in society. Activities where young children are being recruited, harboring, and provided to other people for forced commercial sex acts. And then we have suicide, which we know is our act of instantly taking one's own life. We look at family abuse, and we see developmental abuse patterns that are genetically seen. So sometimes those that come from abuse will then abused later on. We have child abuse. Some indicators we're going to look for are bruises, cuts. Kids will usually be more forthcoming with violence and abuse. They'll usually disclose that when the younger they are, because they may not see anything wrong with it. We know we have neglect that we take a look at. That's where we see people not caring for the children, sexual abuse, intimate partner abuse, and abuse of our older adults, of course. So we know our nursing interventions. We're going to identify our victims. We're going to provide interventions for each level and know that box 27.3 is going to be our prevention strategies for violence. So we're going to be taking a look at all these chapters in our class this week. We'll be doing some case studies, so please do your reading and keep up with the topics that are covered in our chapters. Thanks so much and see you this week. Take care.